Society over the years, and the idea behind this session is to invite someone by invitation and to honour them. And one of our colleagues has been a significant contributor to the Spine Society of Australia over the years, and indeed someone who's contributed to the field of surgeon research in spinal disability over decades. And early last year, when the organising committee began planning for this year's meeting, we couldn't really think of anyone more appropriate than Rob Fraser to deliver this year's address. I was extremely pleased that Rob was able to accept our invitation. As we all know, Australia has produced many internationally renowned and world-changing spinal researchers and surgeons over the years, and Rob's one of them. So Professor Robert Fraser has a personal chair at the University of Adelaide. He was head of the spinal unit at Royal Adelaide Hospital from 1985 to 2005, so that's 20 years. He was a foundation president of the Spine Society of Australia and a past president of ISSLS. He is deputy editor of Spine, and his publications include 120 peer-reviewed papers and 16 book chapters. He has been a recipient of numerous awards from within Australia and around the world. And in 2007, in the Australian Honours List, he received an AM, or Member of the Order of Australia, for service to medicine. On a personal level, I certainly have a very strong memory from my younger years as a junior surgeon of Rob's very approachable and helpful nature. He's a clever and gifted surgeon and very willing to share his techniques and knowledge with lesser beings such as myself. And I also know that in his hometown of Adelaide, he has been a terrific mentor. And I think those guys around him in Adelaide have been very fortunate for that. So I'm really looking forward to this talk of Rob's. I think it's going to interest all of us, from young and old. So it's my great pleasure in welcoming Professor Robert Fraser to the podium for his address entitled Spine Surgery, 1975 to 2005, A Personal Journey. Thank you, Rob.
Thank you. Mr. President, ladies and gentlemen, firstly I wish to express my sincere thanks to the Society for giving me the opportunity to speak about my involvement in spinal surgery over the past 40 years. It has given me cause to reflect, to the point I even considered changing the title to In Memoriam, but not just yet. A great deal has happened since I passed the FRACS midway through my third year of training in 1975. At that time, there was no subspecialisation. All orthopaedic surgeons in Adelaide treated patients with acute back pain and sciatica, and the standard of care was in-hospital pelvic traction for 7 to 10 days. Patients whose symptoms were made worse were viewed with suspicion, as foraminal disc prolapse that often forces an individual to adopt a flexed posture was not yet recognised as a clinical entity. The use of epidural steroids was much less common than today and was often performed under GA, after which the surgeon might manipulate the lumbar spine. The assessment of patients with sciatica often involved Myodil myelography, which involved injection into the CSF of a thick, oily medium through a wide bore needle. At the end of the procedure, this was aspirated, often incompletely, and the patient usually had severe headache and nausea and was predisposed to developing adhesive arachnoiditis. Symptoms associated with constrictive lumbar arachnoiditis were often severe, and some North American surgeons advocated splitting and leaving open the dura. Laminectomies and discectomies were carried out with large incisions to enable the correct level to be identified by finding the sacrum. Laminectomy punches were bulky-ended and were set at 90 degrees, limiting their use for decompressing the lateral recesses. The preoperative assessment of patients with disabling back pain usually involved multiple-level lumbar discography carried out by a posterior approach resulting in several punctures of the dura that produced severe headache, and up to 5% developed severe back pain and spasm from what was called aseptic discitis. The standard fusion procedure was a Wiltse type postero-lateral fusion with iliac crest graft, or less commonly a posterior fusion. There was little use of internal fixation, apart from screw fixation of the facet joints, as described by Boucher. Patients generally remained in hospital for several days or very much longer after spinal surgery. Under the leadership of Brian Cornish, herring distraction rods were used without bone grafting or bracing in the management of thoracolumbar fractures. This was unique at the time, as was the Adelaide concept of trunk control to gauge clinical stability of the lumbar spine and head control to gauge clinical stability of the cervical spine. Dislocations of the cervical spine with or without cord involvement were managed as a matter of urgency by close reduction, followed by open fixation with the so-called east-west or lateral dowel fusion. This procedure, developed by Russell Barbour, preserves the integrity of the anterior longitudinal ligament that is essential for stability of the construct in the absence of internal fixation. The strong belief that restoration of anatomy gave patients the best chance of neurological recovery meant that rapid retrieval, with almost direct admission to the operating theatre, was the order of the day. It was with this background experience that I spent my 4th year of training at the Robert Jones and Agnes Hunt Hospital in Oswestry, which at that time was an AOA recognised training post. A few months before my arrival, John O'Brien had commenced work as the Director of Spinal Disorders, which was a newly created position. John had spent 8 years working with Arthur Hodgson in Hong Kong, where he had developed an international reputation on the management of spinal deformity. In his new role, John had decided to put most of his efforts into the surgical management of back pain, which he felt had been largely neglected, both in terms of diagnosis and operative treatment. Together with the radiologists, Bill Park and Ian McCall, he established protocols for diagnostic radiology to assist in the selection of patients for surgery. The atmosphere at Oswestry under John's leadership was exhilarating, and visits from noted spinal surgeons from Europe and North America, as well as noted researchers from a variety of areas. John's enthusiasm was contagious, and like many others who worked at Oswestry, I decided that spinal surgery, and in particular lumbar surgery, would be my major area of interest. In 1977, I worked as a clinical fellow in Toronto, where I had the good fortune of spending time with a number of noted orthopaedic spinal surgeons, including Ian McNabb, Ed Simmons, and John McCulloch. The founding chairman of the International Society for the Study of the Lumbar Spine was Harry Farfan from Montreal, and I visited this most interesting character. Farfan had been a close friend of the late Alan Dwyer from Sydney, whom he considered his co-founder of ISSLS. Farfan was ahead of his time in his understanding of biomechanics of the spine and the role of torsion in causing annular tears and the protective role of abdominal muscle wall in resisting this. And it was the work of Farfan that stimulated my interest in annular tears and degenerative spondylolisthesis, leading to studies on axial rotation and on the association of DS with childbearing in females and divarication of the rectus abdominal muscles in males. On hearing of my training by John O'Brien in ALIF surgery, the head of orthopaedics at St Michael's Hospital, Dr. John Evans, asked me to show him how to do an ALIF, even though I was only registered on an educational licence. The technique that I had learnt at Oswestry involved the use of a modified carpenter's mortise chisel to cut grooves in the adjacent end plates, into which was inserted a single large tricortical iliac crest graft. I had such a device made up and proceeded to show Dr. Evans how this was done in 2 patients. The first case went well, despite the fact that the only bone punches available were short, round and smooth-ended. But during the second case, I had to repair a tear in the common iliac vein that occurred when the smooth-ended punch slid off the bone graft. Much of my fellowship was spent with John McCulloch, who was a major authority on chemonucleolysis with chymopapain. This enzyme from the papaya fruit was shown to break down the proteoglycan of the nucleus pulposus. The injection of chymopapain for the treatment of disc prolapse had first been reported by Lyman Smith in 1965, but following a poorly conceived and poorly executed double-blind study in the US, the treatment was no longer available there, and patients in large numbers were referred to Dr. John McCulloch in Toronto. Having been trained in the technique of chemonucleolysis, with John's encouragement, on my return to Australia, I carried out a double-blind study to assess its efficacy. The double-blind study was carried out at Flinders Medical Centre in 1979 and 1980 and demonstrated that chymopapain had a significant therapeutic effect when compared with saline as a control. However, the British Journal of Bone and Joint Surgery rejected the work, stating, "We found it a clear account of your study and were not surprised to learn that chymopapain was more effective than saline in the treatment of discogenic pain." When I presented the results to ISSLS in 1982, the Secretary of ISSLS, Marvin Tull, said it was the highlight of the meeting, and the Editor-in-Chief of Spine, Dr. Henley de Rocca, said he would have the paper published within 3 months of my sending it to him. The Adelaide study led to the approval of chymopapain for use in Australia. The results were also used by the FDA, which together with 2 subsequent RCTs carried out in the US, led to its approval and widespread use. In fact, 8,000 orthopaedic and neurosurgeons in the US attended one-day courses during the first 3 months after its release. Unfortunately, because of poor technique and poor patient selection, there were deaths from anaphylaxis and adverse neurological sequelae from intrathecal injection, and these major complications and fear of litigation greatly diminished its use. Soon after, percutaneous discectomy with the automated nucleotome arrived, and this largely replaced the use of chymopapain in the States, although a subsequent RCT showed it to be less effective than chymopapain and probably no better than placebo. The lack of efficacy of the automated nucleotome mirrored the results in a sheep study that we carried out in Adelaide, and the use of this technique never became fully established in Australia. The Australian chymopapain double-blind study demonstrated a significant long-term benefit out to 10 years. What other surgical technique has achieved this? At a time when much emphasis is placed on scientific evidence and best practice, it is ironic that this proven treatment is no longer available for clinical use. In 1983, I received from Rome an unsigned letter, which commenced with, "Who writes is a 26-year-old Italian orthopaedic registrar requesting that he spend time with me." Also, Osti was the first of a long line of orthopaedic and neurosurgical clinical fellows whom I have been most fortunate to have work with me. Also joined me when I had just moved from Flinders to the Royal Adelaide Hospital to set up a spinal service that later amalgamated with the Spinal Injuries Unit. It also coincided with the time I commenced a very productive working relationship with Barry Werner Roberts, Professor of Pathology at the University of Adelaide and a renowned expert on the pathology of spinal disorders. Our first and probably most important series of studies concerned the cause of iatrogenic discitis. This relatively common and most disabling complication of discography and chemonucleolysis was considered by world authorities such as Wiltse, McNabb, McCulloch and Kroc to be due to a chemical or allergic response to the injected material, as evidenced by the lack of identification of bacteria, the elevation of the ESR with a normal white cell count, and the presence of a chronic inflammatory response on histology. The magical moment of my research career was the occasion when Orso and I first examined X-rays of a sheep's lumbar spine that showed the injection of a few bacteria into the disc had reproduced the typical end plate changes of discitis seen in humans after discography. Our various studies in the sheep model conclusively proved bacteria introduced by the needle were responsible for iatrogenic discitis and demonstrated the protective effect of intradiscal and intravenous antibiotic for any procedure that violates the disc space. However, the concept that discitis was due to bacterial contamination was too contentious for the litigiously aware American JBJS, who elected not to publish the initial work after considering it for over 6 months. Instead, it was published in the British JBJS, and a subsequent study on discitis after chemonucleolysis received the Volvo Award for Basic Science. Our second major experimental study that also won the Volvo Award for Basic Science was based on Farfan's concept of disc failure through torsion. It concerned the fate of a peripheral annulus tear in the sheep model, and this was the basis of Orso's PhD. The study demonstrated the cascade of events that followed a peripheral annular tear. It was this work that later stimulated Drs. Jeffrey and Joe Sowell through the company Orotec to develop intradiscal electrothermal therapy, or IDET, with the aim of repairing annular tears and denervating the outer annulus. With the support of the Sowell brothers, Orotec agreed to fund our studies on IDET in the sheep model as well as a double-blind study in humans. They also offered me a very large number of options for shares in their company, which I told them I could not accept as it would compromise my independence. Both studies on IDET formed the basis of Brian Freeman's MD. The results were far from complementary to IDET, and we went through a period of considerable frustration with veiled legal threats from Orotec, causing us to delay presentation and publication of these findings for 18 months. During this period of delay, Orotec cut their losses and negotiated the sale of their company to Smith & Nephew for $258 million US. Depew Spine, which was the Australian distributor for IDET, was privy to our results and declined the option to purchase the company. Our subsequent study of the nerve supply of the annulus in the sheep, which won the ISSLS Prize, provided a logical explanation for the inability of IDET to relieve discogenic back pain. The nerve supply is essentially periannular, with only sparse nerve endings found in the outer few lamellae. During my 6 years at Flinders Medical Centre, I had a close working relationship with the pain clinic headed by Professor Michael Cousins, where epidural steroids were carried out by the posterior route in very large numbers. It became clear to me that this procedure was quite ineffective for foraminal and extraforaminal nerve entrapment, and that better results were achieved with a foraminal injection of local anaesthetic and steroid performed with image intensifier guidance. The results of this technique over a 10-year period from 1986 were reported in the JBJS in 1997, and this was the first published report of foraminal steroids. Since then, the foraminal route to target the affected nerve root has become the most common technique for delivering steroids into the epidural space. When I first joined the Facet Club in 1981, membership was restricted to about 30, two of whom, Richard Vaughan from Perth and Glenn Merry from Brisbane, were neurosurgeons. There was little in the way of scientific studies, and expert opinion prevailed. The meetings were informal and often produced vigorous debates, particularly when it came to the management of spinal injuries. For cervical dislocations, Sir George Bedbrook in Perth strongly argued for a conservative approach with prolonged skull traction. Tom Taylor from Sydney keenly advocated posterior wiring and fusion, and the Adelaide approach under Brian Cornish's leadership was adamant about the benefits of early close reduction followed by interbody fusing using the lateral dowel technique of Russell Barbour. In an attempt to find out whether or not early reduction and fusion provided a better outcome following cervical dislocations, I arranged for Orso Osti to review the case files in Adelaide and at Shenton Park in Perth. This demonstrated that compared with prolonged skull traction, the lateral dowel fusion produced more rapid rehabilitation for Frankel grades C, D and E, but no improvement in neurological outcome, and with an apparent higher mortality rate for grades A and B. After the work was presented to the Facet Club, George Bedbrook surprised me by saying, "I hope you don't stop using this procedure as it is unique, and it would be a shame to use the expertise." In 1989, I was elected chairman of the Facet Club with a proposal to change the name to the Spine Society of Australia and expand the membership base. I contacted the NSA with an offer for them to nominate a representative to serve on the committee that was to develop the Constitution. The NSA declined, and in fact was not at all supportive of the Society until they realised that a majority of Australian and New Zealand neurosurgeons had accepted personal invitations from me to join the Society. For a while, we had a satisfactory working relationship with the NSA, and Peter Riley and I represented our respective societies to produce a document on post-fellowship training. It was disappointing that this cooperative approach did not last, but I was most encouraged by what I heard yesterday from John Fuller and Richard Wilson. On a number of occasions in my career, I visited Harry Kroc in Melbourne to observe, amongst other procedures, his careful and exacting technique for performing a wide decompressor laminectomy that paid particular attention to preserving the pars and respecting the blood supply to the lumbar nerve roots. In 1984, during the 10th anniversary meeting of ISSLS in Montreal with Farfan as chairman, the theme concerned the importance of abdominal muscles, including their attachments through the various facets to the spinous processes and transverse processes. This awakened in Harry the memory of a paper from an Indian surgeon that he had rejected when serving on the editorial board of the British JBJS, and as far as I'm aware, it was never published. The technique involved detaching and retracting the multifidus on each side while preserving the midline ligaments, and this was followed by osteotomizing the spinous processes near their bases, which allowed the midline osseous ligamentous structure to be retracted to each side. On Harry's recommendation, I started using this technique, but at the suggestion of Brian Cornish, modified it by separating the multifidus on one side only. We have continued to use this approach and believe it has major advantages over traditional laminectomy and bilateral laminotomies, including the ability to adequately decompress the lateral recesses while preserving facet joint integrity, reduce the dead space, retain the posterior tension band, and provide a better anchorage for the posterior muscles. It can also be combined with a Wiltse muscle splitting approach for the insertion of pedicle screws or to access the extrafemoral region. In 1980, I arranged for Harry Kroc to spend a week in Adelaide as a visiting professor. At Harry's request, I carried out a 2-level ALIF procedure with Harry and his wife Carmel assisting me. When I had first started at Flinders Medical Centre, I used the Rutherford-Morrison muscle cutting approach that I had learnt at Oswestry and that was widely used at the time. However, on the basis that the preservation of abdominal muscle wall was important, I had developed a muscle splitting approach, and it was this that I demonstrated to Harry. The following year, when I returned to Oswestry to attend a symposium organised by John O'Brien immediately before the ISSLS meeting in Paris, I happened to be sitting next to Dr. Lee Wiltse. Thinking that Dr. Wiltse routinely used his postero-lateral approach that was so well known internationally, I asked him if he ever carried out an anterior fusion. He said he did. I asked him what approach he used, and he said, "I use yours." Believing that he must have thought I was a fellow working with John O'Brien at Oswestry, I said, "The muscle cutting approach." He said, "No, your muscle splitting approach." I said, "How did you hear about that?" To which he replied that Harry Kroc had demonstrated this when he had visited him in Los Angeles. Wiltse was a highly regarded person, and it was no accident that he was the founding president of ISSLS and the founding president of NAS. Furthermore, both organisations have a Wiltse Lifetime Achievement Award that acknowledges his legacy. In 2003, when I was president of ISSLS, Lee Wiltse was about to turn 90, and I made a special presentation on his life at the banquet. During the evening, Lee's wife, Dorothy, who had provided me with much of the material for my talk, told me that she thought this accolade was just in time as she had noticed Lee's health had deteriorated. This was prescient, as a few months later, Lee had a seizure and subsequently underwent surgery for a brain tumour. His daughter told me that on the night before the operation, the whole family had gathered in hospital viewing a DVD recording of the presentation I had made of Dr. Wiltse's life. This probably mentioned a few things Lee had forgotten about, which adds meaning to one of my treasured documents, a letter I received from Lee many years earlier in which he wrote, "I always learn something new when you speak." The muscle splitting approach appeared in the British volume of the Journal of Bone and Joint Surgery in 1982. It was developed in recognition of the important stabilising role of the abdominal musculature. Harry Kroc later generously described the approach in his first edition of his classic monograph, Practice of Spinal Surgery. Several years later, I changed the approach to lessen damage to the anterior abdominal wall, and this modified approach was published in Spine 10 years after the original publication. In 1996, with the advent of the artificial disc and the requirement to consistently gain direct anterior access to the anterior annulus, I developed an approach between the rectus abdominis muscles, and it is this approach that I have routinely used for the past 19 years. To aid exposure, I designed and had manufactured by engineering firms in Adelaide short vertebral pins and a windowed retraction system enabling the procedure of ALIF or disc replacement to be carried out safely through a smaller approach. The key to adequate access is the safe mobilisation retraction of the great vessels, and this is more challenging in the presence of a transitional vertebra as the vascular nature changes and the bifurcation of the inferior vena cava consistently lies over the functional lumbosacral disc. It was in 1982, the year that Harry Kroc and George Bedbrook published their paper on anterior lumbar interbody fusion, that I embraced the Kroc method of ALIF. This elegant and reproducible technique involves the removal of disc and end plates with dowel cutters and the insertion of two corticocancellous grafts taken from the anterior iliac crest with a larger diameter dowel cutter. A few years later, I started supplementing ALIF with posterior distraction instrumentation using threaded knot rods as advocated by John O'Brien. However, the turnbuckle rods were fiddly to use and there was a significant incidence of rod breakage. With the help of Billy Hutton, who at the time was Professor of Engineering at Adelaide, I designed and had tested a posterior distraction system which was named OzRods, the first instrumentation to use grub screws. These were made at the University of Adelaide and were packaged by my secretary in my rooms and sent to various surgeons interstate and overseas, including John O'Brien in London. How times and regulations have changed. In 1989, I commenced using pedicle screws via the Wiltse muscle splitting approach, initially in combination with ALIF, and then because the fixation with Steffi plates and screws was so powerful, I carried out a series of pedicle screw fixation with postero-lateral graft alone. Charles Greenough was the independent observer in a retrospective review of 151 consecutive ALIF patients with a minimum follow-up of 2 years. 76% had a solid fusion and 68% had a satisfactory outcome according to the low back outcome score, which Charles had developed under my supervision as part of his MD. As with our other studies, the outcome was not related to the attainment of a solid fusion. When compared with a consecutive series of pedicle screw fixation and posterolateral grafting, ALIF had a lower fusion rate, but a superior clinical outcome, supporting the role of disc clearance and interbody stabilisation. In our 10-year follow-up of 125 consecutive ALIF patients, non-union was determined by loss of bony continuity, with beaking or graft fragmentation, and fusion was determined by continuous trabecularly with obliteration of the disc space. On this basis, the fusion rate was 90% for one-level ALIF, but only 50% for two-level procedures. In our study of adjacent level degeneration, 52 patients with preoperative normal adjacent discs on discography were assessed by MRI 10 years after ALIF. 10 years after a solid ALIF, a previously normal adjacent disc was still normal on MRI in 68%. The same cohort of patients was assessed again by MRI at 20 years following ALIF. Adjacent level degeneration had increased from 32% to 47%, which is comparable to MRI reported prevalence of degeneration. It is important to note that significant stenosis was present in less than 5%. And 20 years after ALIF, less than 10% of patients had required surgery at the adjacent level. It would seem that after ALIF, the occurrence of degeneration is determined far more by individual characteristics than by the surgery itself. In 1993, the Brantigan ALIF carbon fibre cage became part of my standard ALIF procedure. In 1999, we published our preliminary results in which we coined the term locked pseudarthrosis to describe incomplete fusion within the mid-substance of the cage. The incidence of locked fusion with ALIF was significantly less with supplementary posterior instrumentation, although this did not significantly improve the clinical outcome. Most of the papers published in the literature employ the FDA criteria of fusion assessment that is far too generous. When applying the FDA criteria, we found the fusion rate was virtually 100%, whereas with thin section CT scanning, it was only 65%. In another study, we used thin section helical CT to compare the rate of interbody fusion for 4 different fusion techniques. The results added support for supplementing ALIF with pedicle screw fixation and posterolateral grafting. However, there was mounting evidence of the detrimental effect of posterior instrumentation on the adjacent level, particularly when there was loss of lordosis. Damage to the facet joint at the time of surgery is not the only factor. Increased stiffness of the pedicles produced by the screws within their substance, and posterolateral bone graft that also abuts against the superior articular process are collectively responsible for increasing the risk of developing spinal stenosis from hypertrophic facet osteoarthrosis. The treatment of a degenerative spondylolisthesis of L4 with rigid posterior construct transfers torsional forces to the adjacent level, and this often produces a similar pathological condition at that level. By contrast, we have demonstrated that ALIF is associated with a very low incidence of subsequent adjacent level stenosis. It is the retained springing through the pedicles that protects the facet joints, and evidence for this is seen in the preservation of facet joint surfaces up to 20 years after solid anterior fusions. It was with these considerations that the DePuy anterior lumbar plate was designed. The aim was to sufficiently increase the stability of an ALIF fusion construct such that supplemental posterior instrumentation could be avoided in most cases. In 1998, I had presented DePuy with sketches of a cage with an anterior plate attachment. I knew that cages had been tried with screws passing through the middle of the cage and into the end plates, but I considered it would be mechanically sounder if the screws were to pass anteriorly through the vertebral rims, with angled tabs on the plate to facilitate this and to reduce the anterior prominence of the plate itself. DePuy was receptive to the concept, and the design was refined and tested in cadavers. When it came to a pilot study in humans, it was apparent that it was better for the plate and the cage to be independent of each other to allow for the wide variations in anatomy. After a successful trial in 50 patients, the plate was further modified with input from Dr. John Miles from the US and was given the name Aegis. The Brantigan cage, which was modified slightly and was renamed Cougar 1, was then used. Other than for my personal use, it took many years before DePuy Spine decided to make available the cage I had designed with a slot for the inserter. The original Oz inserter, designed and manufactured in Adelaide, was made to engage with a device that had slots. Subsequently, DePuy engineers in Raynham made minor modifications to enable the Oz inserter to control a cage without a slot. And when an application was made for a US patent, I was not particularly impressed that mine was the last of 4 names listed as inventors. In 1993, Dr. Arthur Steffi was involved with 2 artificial disc procedures in Australia, one in Melbourne and the other in Adelaide. They were part of 8 subjects in an FDA IDE study on the AcroFlex silastic disc. I had the privilege of inserting the disc in Adelaide with Dr. Steffi assisting me. Afterwards, he gave me a set of smaller silastic artificial discs designed for the cervical spine, and I suggested they be tested in the sheep lumbar spine. Negotiations with Acromed for funding and support for the sheep study dragged on until I received a letter from Acromed telling me that they had just carried out a US study in the cervical spine of goats, and that a number of the implants had come apart, and as a result they were no longer continuing with the silastic device. I wrote back stating that it was not surprising the discs had failed given the goats' habit of headbutting, and asked why they hadn't followed my advice to separate the sheep from the goats. Despite this comment, the following year I was asked by Dr. Steffi to be part of a surgeon team that would design a new artificial disc. The first of many face-to-face meetings over the next 6 years took place during the ISSLS meeting in Vermont in 1995. The whole process was an eye-opener for me, given the resources and large numbers of personnel that were allocated to the project. After due consideration, the decision was made to continue with the AcroFlex concept, but to change the polymer from silastic to polyolefin. Based on testing information provided by the engineers, we agreed to accept the method of bonding to the titanium end plates that were already patented by Acromed. Most of the surgeon input on design concerned the metal shape of the titanium end plates and the instrumentation for insertion. In hindsight, there was an undercurrent to advance the design as quickly as possible, to dramatically increase the value of the company so that it could be sold to meet the costs of pending large financial burdens, including a class action against Acromed over pedicle screws, which later settled for $100 million US. I was not happy with the original end plate design that was flat, and Arthur Steffi's suggestion had a crescent-shaped protuberance to stop back out, which I later named the Steffi wart. My concerns were confirmed when Acromed engineers were unable to come up with a workable inserter, and simply hammering in the implant would damage the end plates and the rubber. I worked with a local engineering firm in Adelaide to produce a lever system, the precursor of the Oz inserter, for insertion of the device, and I used this with some difficulty for the first 11 cases. The subsequent changes to the end plates were all based on my suggestions and included contours to match the curved bony end plates, fins to prevent back out, and a slot to work with an inserter. Although there were technical problems with a small series implanted in the UK, the early results in the Adelaide series were encouraging, and plans were made to carry out an international multi-site trial comparing AcroFlex with ALIF. However, at a face-to-face meeting in the US, I was concerned when I became aware of the results of a baboon study carried out in the US at the request of the FDA. Very small implants were used, and some of them developed tears in the rubber with black staining of the adjacent tissues. The US pathologist employed by Depew stated in his report for the FDA that this was due to improper manufacture of the polyolefin, causing extravasation of small particles, but with no evidence of bone lysis or resorption and no evidence of foreign body reaction. The tears were considered to be due to the fact that the implants were very small and had been designed only to test for tissue reaction, and not for standing up to the punishment meted out by the chief baboon when a weakened baboon was returned to the cage. I was not convinced and requested the histology be examined by Barry Werner Roberts for any evidence of bony foreign body reaction and osteolysis. I also stated it was my intention to ask all subjects in Adelaide to undergo a CT assessment for rubber failure, which I did despite objection from the radiologist on the team on the grounds it was subjecting patients to an unnecessary additional radiation. The planned multi-site study was aborted at the 11th hour after the CT assessment of implants showed a high incidence of early rubber failure, and Barry Werner Roberts' examination of the baboon histology confirmed my suspicion that the wear particles were associated with a foreign body reaction and osteolysis. What have we learned from the AcroFlex pilot studies? At 2 years, the results for AcroFlex were comparable to ALIF. At 10 years, 11 of 28 implants required revision. And for those that survived, the device did not preserve motion and did not protect against adjacent level degeneration. Most important of all, the study demonstrated that it is vital to carry out an adequate pilot study to rigorously test any new device before release on the market. Ladies and gentlemen, over the past 4 decades, there have been numerous advances in the understanding of spinal disorders and their management. The account I have given has focused mainly on the lumbar spine, with an emphasis on some of the topics that have been of particular interest to me. In concluding, I wish to thank my colleagues at the Adelaide Centre for Spinal Research and the Royal Adelaide Hospital for their wonderful support over the years, and also to thank the Society for giving me the very great honour of addressing you today. Thank you very much.